this is a slide we presented before that just shows the mechanism of action of P. gingivalis, which is an unusual bacteria for two reasons. It gets inside of the cell. It's intracellular. It's a cell that gets inside of cells. And it's asaccharolytic, meaning it doesn't consume carbohydrates for its fuel source, but proteins instead. It does that by releasing these proteases called gingipains from the gingivitis literature that go around chopping up a lot of important proteins on the inside of the cell, essentially digesting it from within. And it's been known for years. This has been a target in the dental literature because of gingivitis and periodontal disease, the more severe form. And it's known that traditional antibiotics are ineffective at knocking this drug out. In the mouth, it hides in biofilms and things like that. It can develop resistance. It's intracellular where a lot of antibiotics don't penetrate. So for a lot of reasons, the bacterium itself is a bad target. So we developed Core388 and Core588 as targeting these gingipain proteases. So they're called gingipain inhibitors. And once you do that, and they bind covalently and therefore permanently, they by knocking out the proteases, you stop all the pathology, but you also then cut off the food supply to the bacterium itself. So that's the mechanism. This slide just depicts the fact that there's really a lot of converging scientific evidence for this theory. There's observational clinical studies, animal models that I'll show you a little bit. Periodontal disease is one of the strongest epidemiological predictors of Alzheimer's disease, and that's been published in multiple papers. The other point this slide makes is that the vast majority of these bullet points, the ones highlighted in red and orange, were either done completely independent of Cortexime or in collaboration or have been replicated by independent labs. So it's, I think a highly credible database. And then this is just one piece of that database. This is the mouse model. If you take a very simple, non-genetically modified wild-type mouse and just rub P. gingivalis on their teeth and gums, that infection penetrates the brain. It increases the level of amyloid beta. It increases the levels of inflammatory measures like TNF alpha, and it kills off some of the hippocampal neurons in the brain. And that mouse model, the pathology of PG in a mouse or a rat has been replicated in 5 different labs independent of ours. But then we are the only ones who have Core388. So then we took this mouse model and we treated them with Core388. And you can see it knocks down the bacterium level. It reverses the amyloid beta increase. It reverses the TNF alpha increase, and it fully protects the hippocampal interneurons from dying. And interestingly, the new data from the GAIN trial are some biomarker data, including inflammatory markers and hippocampal brain volume in humans. So some of the new data will correlate nicely with these mouse data. This is just a depiction of the Atuzaginstat Core388 GAIN trial. It was a year-long trial, 2 different doses, 643 patients. A couple of key things. Remember, this is in mild to moderate. So these are much more severely ill patients than those that are being targeted with most other most other Alzheimer's treatments, like the amyloid anti-amyloid monoclonal antibodies, which are studying mostly in the 20 to 30 range or 22 to 30 or above. The other kind of unique feature is we have these biomarkers of P. gingivalis consistent with our mechanism. These are the baseline demographics that were presented previously at CTAD. Very quick takeaways. The treatment arms were pretty balanced overall. The demographics are very consistent with mild to moderate Alzheimer's. And we stratified by APOE4 carriers and non-carriers and by mild to moderate Alzheimer's. And these are the primary outcomes. We also presented these before, just as a reminder. On the overall intent to treat population, we did not see any significant slowing of progression, either on the primary parametric analysis or on a pre-specified sensitivity analysis that was a non-parametric analysis, because a lot of the data were non-normal which indicates that you should use non-parametric inferential statistics. But very importantly, a key goal of the study was to test which population might be responsive to this drug. And so we pre-specified in our statistical analysis plan patient cohorts in which we expected greater drug effects, those with greater evidence of PG infection consistent with the mechanism. And we also pre-specified correlations between markers of PG infection with clinical endpoints. So we looked at the high PG infection in 3 different ways. Again, these are all pre-specified. We did a test for the PG DNA in saliva, and then we did tests for human IgG that was specific to PG. These are human immunoglobulins in the serum and in the cerebrospinal fluid. In the saliva, this was a simple detected above the level of threshold or not, and 38% of the patients were positive. The IgG in serum and CSF, we saw positive in 100% of patients. So we simply did a median split, high versus low. And you can see that the interactions are significant, meaning there was a significant PG load by treatment arm statistical significance in both this group and this group. This one didn't meet the traditional significance level of the nominal significance level of 0.05. You can see the trends were in the same direction. Some of these reached nominal statistical significance too. Overall, you see 26 to 57% slowing fairly consistently across these different cohorts. And by the way, these are biomarker data. The groups are defined by biomarkers. And then again, as before, we did sensitivity analysis with non-parametric statistics, which are generally considered to be a little more conservative, but primarily the goal of doing a sensitivity analysis is not to see if this is significant or that significant, but to see if the magnitude of effect is fairly consistent or not. If it's not fairly consistent, you're in trouble. Fortunately, here we see, if anything, it's a little bit better, 40% to 56% slowing. And you can see just by looking at the curves, pretty consistent across all 3 of these groups, and pretty consistent, more consistent than not, with the parametric analyses. An important takeaway from this is, to our knowledge, in this severity of population, no one's ever shown this magnitude of slowing of progression. We're conservatively calling it 30 to 50%. And people have seen this in more mildly ill groups with the recent aducanumab, lecanemab, and donanemab data. Those we're looking at MMSEs of aducanumab was 24 to 30, lecanemab was 22 to 30, and donanemab was 20 to 28, where we go all the way down to 12. So it's a much sicker population, and to our knowledge, no one's shown this level of efficacy, even in a subgroup in this population. And then these are biomarker correlations. This is, again, these were pre-specified. And again, this is a biomarker. It's change in the PG level over the first 24 weeks, and correlating that with these clinical responses at both 24 weeks and 48 weeks. There's an important comment to make on the statistics, because I'm going to show you a bunch more statistics on biomarkers. But there are many comparisons we did with many different outcome measures, and there's no way to properly adjust for multiplicity. So I will typically refer to these as nominally statistically significant or not. Because of this, I wouldn't focus on a p-value cutoff of 0.05 as being all important. So for example, we happen to have a 0.04 here and a 0.06 here. I would not be strongly confident that the 0.04 is meaningful, and I would not be strongly confident that the 0.06 is not meaningful. What I would focus on is the overall weight and consistency of the results. I would focus on the magnitude of effects, such as 0.33 correlation here. And finally, the one other thing you can kind of be reasonably reliable on, even with multiplicity, is that when you see p-values as small as 0.0001, the likelihood of that being a false positive is rather low. So here, all 8 are in the right direction. 5 out of 8 are nominally statistically significant. So the weight of the evidence seems fairly consistent. And the magnitudes of the correlations, 0.20 to 0.35 in many, are actually very, very strong correlations for, these clinical outcomes are notoriously variable. So that's those are some more clinical data. These are the safety data. I presented these before just to remind you and have a somewhat balanced presentation on safety and efficacy. And overall, Atuzaginstat is pretty well tolerated. GI adverse events in kind of the mid-teen range being the most common. The most important safety signal we saw, though, was that up to 15% of patients on the high dose had elevated hepatic labs, ALT and AST. And 2 patients on this higher dose of ADBID met Hy's law criteria, which carries a risk of hepatic failure. And we're continuing to research these mechanisms, the potential mechanistic causes of LFTs, and we hope to have more data on this in the near future. And we're also, as we discussed, advancing our next generation molecule, Core588, which we hope to help manage this going forward too. And it's always important to evaluate safety in the context of efficacy, which we've already talked about, specifically in this higher unmet need population. And it's also important to keep in mind the alternatives. So whereas we're seeing an important hepatic signal with our drug, some of the other treatments under exploration right now cause ARIA. And those in, again, a small number of cases can be more severe with things like strokes and seizures and deaths have been reported. And with our mechanism of action, we don't see any evidence of ARIA. So that's the pros and cons. Now let me turn to some of the new data across. These are some of the biomarkers we have from the study. The red ones are the ones I'll be presenting today. So there'll be more to come in several future presentations this year. And we focus first on target engagement and then on the mechanism of action and further downstream disease measures. This is evidence of direct target engagement. Atuzaginstat binds covalently permanently to the gingipain proteases, as we said before, to deactivate them. And this is an activity-based probe specific for the active site of the lysine gingipain. Examples of this assay are measured with a fluorescent labeled gingipain activity probe, which is depicted on the right. Note that all of these are in the right direction. 3 out of 4 meet the nominal statistical significance. So the overall weight of the evidence is supportive of this target engagement. And then again, the prior slide I was showing you mean percentage changes from baseline, and this is non-parametric median percentage changes from baseline and a non-parametric inferential test. And again, all of these are in the right direction. 4 out of 4 are in the right direction. 3 out of 4 are nominally statistically significant, and the magnitudes are pretty substantial. So that's encouraging for target engagement. And then moving to some mechanism of action measures. These are the anti-PG IgG antibodies, and this is in the overall intent to treat population, and in the PG with detected in the saliva, the high PG infection group on the right. And again, all 4 results are directionally consistent with the PG hypothesis. 3 out of 4 again are nominally statistically significant. And this is a pattern I'll show you on several of the upcoming slides. There's numerically greater separation in this high PG infection group than there is in the overall population. Again, these data are consistent with the hypothesis overall and with those mouse findings I covered earlier. Then here's moving down to some disease biomarkers like A-beta 42 over 40 in the CSF. This is expected to increase with treatment. And while there are numerical changes, all 4 are in the right direction supporting the PG hypothesis. These were all, as you can see, of pretty small magnitude and not nominally statistically significant. So, consistent with the hypothesis, but certainly not a slam dunk on this biomarker. The CSF biomarkers continuing with P181 tau and total tau. Again, the overall population on the left, the high PG infection on the right. And again, you can see here with these downstream markers, there were numerical changes in the expected direction, more in the p-tau 181 than with total tau, which showed very small changes. And that's consistent with the hypothesis. But again, most of these were pretty modest in size and only one reached nominal statistical significance. Then moving to brain volume, again, I alluded to this with the mouse model. We looked at 3 different measures of brain volume, bilateral hippocampal volume here, And you can see that in the placebo group, this only declined by a little over 1%, which is much smaller than most of the literature shows on this population, which ranges up to about 5%. And again, none of the arms produced nominally statistically significant changes, but again, all the numerical changes were in the right direction, favoring the PG hypothesis. And again, the pattern with the high PG infection group was a more consistent dose response pattern and larger magnitudes in general, again, supporting the hypothesis. We also, down here at the bottom, saw nominally statistically significant correlations between the bilateral hippocampal volume and these co-primary clinical outcomes. One of them was nominally significant. The other was a very small correlation and not significant. But then moving on to cortical thickness, again, not much trend at all in the ITT population, a better trend in the high PG infection population. And again, modest changes, not statistically significant, but directionally supportive of the hypothesis. And here the correlations between this brain marker and the clinical outcomes these are very high correlations, again, for these notoriously variable clinical outcomes and very high, very low p-values, suggesting that these are very, very unlikely to be false positives. And with whole brain volume, again, all in the right direction, none statistically significant. Again, the PGDS group has a little bit more of a dose trend in the right direction, again, supporting the hypothesis. And finally, again, correlations here we've completed for both the intent to treat and the high PG infection populations. Again, you can see very high correlations for this kinds of data, and a little bit higher in the PGDS group than in the intent to treat group on both of these clinical outcomes. Again, all of these trending to favor the PG hypothesis. And again, these correlations have p-values make them very, very unlikely to have happened by chance. So those are the key new data. To summarize, in background, there are extensive convergent data supporting the role of PG as an upstream driver. The clinical results showed 30 to 50% slowing of decline in patients with mild to moderate Alzheimer's and markers of high PG infection. Again, we think this is unprecedented in this severity population, to our knowledge in the literature. And the overall weight of the evidence from these new biomarkers presented today reinforced the findings that Atuzaginstat showed evidence of direct target engagement. It impacted multiple additional downstream biomarkers. All markers were numerically supportive of the mechanism of action, and the biomarker clinical correlations were amongst the highest we've seen in the AD literature for these kinds of outcomes. And again, reiterating something I mentioned earlier, you saw that we haven't presented all the biomarkers yet. It's the GAIN trial database is a very large, very rich database, and we expect to have more data continuing to come out later this year and presenting those at scientific conferences again later this year. So that's a quick summary of the high level of the background and the newest data.